we listed yesterday for you to see. So I'm going to welcome the two representatives of the team that are working on an innovation around data. And I think David Taylor Robinson, so welcome David Taylor Robinson on the stage, who's going to begin on this, and then I think Anthony's going to join you. So, and then we'll have time for Q&A. David, over to you.
Thanks, great to be here, everyone. Don't fall asleep. We're nearly there. So I'm going to begin for the first few minutes and try and show some data and some data innovation, hopefully, and then hand over to my buddy Anthony. And I guess, yeah, a cast of thousands involved in this, 8 of the members. And one of the great things, Ashley, that you've done is bring everybody together, as evidenced by the meal and the bonhomie last night and all of the high-quality discussions. And we need to address these problems together because inequalities are all moving in the wrong direction. I'm going to show 3 graphs that I find particularly shocking. This is data that Shayon Ehsan put together for one of our Child of the North reports. The dotted line there shows the gap, the inequalities in infant mortality over time. So inequalities are going up, and they're the same as in around 2010. So we've seen 14, 15 years of stagnation on infant mortality. This shows rising inequalities in maternal mortality, women dying during pregnancy. And the inequalities we see are the highest since we started recording data on maternal mortality in pregnancy. And this is life expectancy. We know that life expectancy is stalled pre-pandemic, started going backwards, particularly in disadvantaged women. And life expectancy now in men is similar to that in 2012. So again, a huge period of stagnation. So we've got a lot to do, and we've done a lot of that work through the school. So in the COVID report that we put together, and work that we've done subsequently, we've shown rising inequalities in infant mortality, life expectancy at birth, healthy life expectancy, the modern epidemics of childhood obesity, child mental health problems, inequalities increasing, maternal mortality, kids being taken into care, educational attainment at most stages, we're seeing rising inequalities, and vaccination uptake. So the Minister talks the talk around the healthiest generation of kids ever, but there's a big challenge in order to put that into practice policy-wise. And we know what's driven these trends largely, driven by austerity, rising poverty. Mental health problems are at the heart of what we're seeing here. So I'll turn to some data on that. And I guess the great hope is that with all of this rich linked data, we might get some traction on these issues. But I'd argue that unless we put equity at the heart of thinking about how to use these data sets, and unless we take a life course approach and focus on big public health issues, the data sets won't be the solution to the problem. You know, people have talked about large hadron colliders when it comes to data, and across our collaboration, we're sitting on some really rich data assets. So small area level linked data, the place-based longitudinal data resource that we developed in SPHR 2, area-level linkages coterminous with integrated care systems like WISIC, which in London, like the CIPHER dataset in Cheshire and Merseyside, and One Devon, birth cohorts, population-level data on children in England, the eChild dataset, and the SAIL data bank. And yeah, Sarah Martin Denham and Nathan Scott, I met Nathan at the Do last night, who are involved in this piece of work, did this really nice report on the extent to which ICBs are using that data. There's obviously lots of linkage within health, but there's much less linkage across local authority data sets and cross-sectoral linkage, and much less use of some of the rich data that's collected at local authority level, and patchy use of linkage to address some key children's health issues. So we said we'd do this type of thing. We'd use some of those data sets. We'd focus on using triangulated methods across different data sets and different epidemiological approaches. We'd link some trials use linked data to follow up some trials, and would focus on some children's mental health data sets, particularly eChild. And I'm going to talk a little bit about the first one and some of the linked data that we've got. So, yeah, as I've said, these are the main data sources that we're going to be using in the AfRI, and I'm going to present some data from SAIL. And we hope to use these data sets to look at things like mental health, children being taken into care, special educational needs, some of the key public health priorities at the moment. And just turning to, a critical policy issue at the moment, we've seen a doubling of mental health problems in young people, also in other age groups over the last 10 to 15 years. And the government are terrified at the moment because mental health problems in young people is a massive budget pressure because of disability benefits, leading to the government saying they're going to cut 5 billion from disability benefits. So using SAIL data, we were interested in looking at the emergence of mental health problems in a whole population cohort. So this is using linked data in Wales. We've been working with colleagues in Swansea, Stu Bedson and Sarah Aldridge in the SAIL data bank. And this analysis links a whole range of data sets together for 1 million kids born from the year 2000 onwards. So the whole population of Wales from the year 2000 onwards. And because SAIL do a lot of this, we've got one of the innovations here that is that in SAIL you can use both HES codes, so hospital diagnoses of mental health problems, and also READ codes, so GP level data. So we've been able to instrument a whole range of problems. This is kind of hot off the press, so I haven't actually got the inequalities data yet out of SAIL, but I'm going to show you trends. And here I'll show you, this just shows gender differences. This is the cumulative incidence as kids age of mental health problems. And in SAIL, about over 20% of girls develop mental health problems by the age of 18 in the SAIL data bank, lower prevalence in males. And then you can look at specific conditions. So this shows the dramatic rise in anxiety and depression diagnoses in girls. Conversely, this graph shows the cumulative incidence of conduct disorder. And we know conduct disorder is more common in boys compared to about double the prevalence in the data set. This shows eating disorders, which we know is a big problem in older hay, and you can see the huge tick up in eating disorders from around age 13 onwards. And we can look at all of them together for girls and for boys, and you see the difference in prevalence there. So this is kind of proof of principle that we can instrument these conditions in a whole population data set. We're going to go on to looking at how perinatal factors and policies influence these trajectories. We're obviously going to look at inequalities. We've seen the inequalities data and it's really stark, and we'll show that in due course. And then we can also look at the link between social conditions at birth, mental health problems, educational outcomes, children being taken into care. And we'll try and do this across a number of the data sets that we have access to. So a powerful platform for inserting some evidence into these really difficult policy decisions that government are dealing with at the moment. And over to Tony.
Thank you, David. Thanks, David. Thanks, everyone. So it's my job, my pleasure, to talk in a little bit of a whistle-stop way about the other 3 bits of the AfRI. So again, don't fall asleep. There's some more data hot off the press to come. So the second part, triangulation. I'm sure people are familiar with this, but really we are planning to look across different contexts, different data sets, use different methods to try and unpick what we can find out about these substantive areas, provide methodological learning for our partners in SPHR, and also, really get to grips with how we can deal with these things. It's worth saying that this, like a lot of things, it is based on previous work in SPHR 2, where we had triangulation approaches. So these are some 2 papers looking in Liverpool and in Wales at factors behind children being taken into care. And so this is a sort of example of, you can do similar analyses in different areas and see what you can find there. Specifically in the second work package, so this is focused on, what are the intersections between mental health, physical health, smoking, and employment. Plans are to do that in 3 data sets: understanding society, a national cohort, and we've heard quite a lot actually about understanding society and using that to look at mental health, which is really great. So some big linkages there. The Millennium Cohort Study, a national birth cohort, I imagine people could be familiar with, and also this Discover Now data in Northwest London. So that's the artist formerly known as WISIC. They've rebranded it, but that's an integrated platform of about 2.8 million people in Northwest London. Healthcare, social care, various things are in there. Just a little bit of fresh off the press data. So it's worth saying that it's Alan Brennan and Steve Hope and Yekta Saeed are involved in this. And this is just 2 graphs from Yekta. So this is just looking at understanding society, this quite crude measure of employment, what is happening over time. And you can see these sort of blue. I mean, I'm colorblind, so I don't know why I continue to tell people they can send me slides and I can talk about them. But unemployed people and inactive people, that is increasing as a proportion over time. And so that, really fits with other evidence on what we know there. And also this is just sort of illustrative, looking between current smokers and ex-smokers, their GHQs of measure mental well-being. And these are the early stages of trying to unpick, what are the interactions between mental health and people smoking? Do you quit smoking because your mental health has got better? Does your mental health improve after you quit smoking? And so these questions sort of remain to be unpicked a bit. Got this focused series of questions. This last slide, this last point is maybe the most important one. We're finalizing this overall protocol. We're going to send it around people that we think will be interested. If you think you would be interested, let us know. We can definitely send that to you. But as I've said, how do these interactions across mental and physical health and employment and smoking, how do they differ across the data sets and also across different methods? Do different methods allow you to predict things happening in different ways? Can you get different information out of this? And then potentially sort of modeling intervention effects. So we can say, this is what we think is happening. This is what we think an intervention would achieve. So this is where that is going, but do let us know if you want to be kept posted on that. The third bit, data-enabled evaluation and trials. So this is GJ Melendez-Torres and Francesca Crow. And so we've heard a lot as well today and yesterday around school-based interventions, cluster randomized trials. And so, one thing I think has come out a bit there is that, being able to embed routine data in these cluster randomized trials has, big potential benefits. So that means that you can, maybe you can link to different bits of data and sort of find out things that are not feasible or not currently being done in big, expensive cluster randomized trials. This is a lot of words from the overall application, but from these project aims, I would say the 2 main things are the plan is for this to enable longer-term follow-up. So it's very expensive to go to schools, collect data on children, collect data on what's happening. And so if you can develop a platform where you are doing that, by linking to routine data, that means you can do that for a much longer period of time. But also, you can imagine if this happens, this is going to be more efficient than, having to visit schools and so on. GJ sent me this quite complicated graph, but the main thing, informally, the main thing to say here is that there's a process and it's well defined and it's going to work. I am assured, going to work. But a bit more seriously, the plan is to identify these cluster randomized trials where we think it's going to be useful and feasible to link to routine data, sort of going through a process of identifying those trials, identifying those PIs. At the minute, asking people for consent, can we link this school data to other bits of data, and then, go ahead with the actual linkage, link it to data around what is happening in mental health, are people visiting services, what are the interventions happening, what are their outcomes. So this is overall where this work is going, and and sometimes it's good to know that what you have said in your application and what you say as a justification for your work is actually true. And so part of this hinges on the idea that there isn't very extensive longer-term follow-up of these cluster randomized trials. And so the team, it's ongoing, but they've had this review, which has various findings, but it says that, there isn't at the moment lots of linkage to routine data. And also crucially, most follow-up periods are 6 to 12 months. So linking to routine data is going to enable us to extend that. The fourth and final part, data for child mental health. So it's Judy Kidger, who I saw somewhere, and Tamsin Ford leading this. And so this graph, this figure, I think this is no surprise to anyone in the room. So if you look at deprivation quintile by measures of probable child mental ill health, you see the picture that we would expect. It's got a little bit worse over time. It's much worse in more deprived areas, and so the plan is to link different bits of data to innovate in this area. But for this fourth part, I just want to talk about some of the PPIE, which has been done and which is ongoing. So they've had this sort of Miro interactive whiteboard, and so what's happened there is the team have put together what they think are the factors influencing children's mental health. They've gone to the kids and said, does this make sense to you, and is there anything you would add to it? And actually, this is sort of what it looks like, lots going on here, but unsurprisingly, they have added things to that, right? And so some of the things they have added to that is they've added, which I found really fascinating, we talk about social media and peer pressure as, potentially negative for child's mental health, but actually one specific mechanism that young people here talk about is they say, well, seeing people live a lavish lifestyle on social media, which is maybe not true, but that creates a sort of financial stress. You think, why has Tom got enough money to be, I don't know what he's doing, doing something fancy when I actually don't have money for that. And so that real interaction between, financial stress, peer pressure, and social media, very interesting. And so just finally, this is, as David says, a cast of thousands. Thousands is maybe rounding up a little bit, but quite a lot of people. But all of the members are involved. It's ongoing, obviously. So we're focused on collaboration. We're keen about that. So if you're not involved and want to be, talk to us. That would be great. And very much, I would say, these are all the great things we plan to do. But a bit more informally, the plan is to innovate around methods and data linkage, but also innovate and have sort of substantive findings, which I think we are starting to see come out. And look forward to the rest of it and any questions people have.
Okay, thank you both so much, David and. I heard you called Tony before, Anthony, so I'm not going to call you Tony. I think it's important to recognise that these areas for research innovation are exactly that, and there's an element of we just don't know here, and there's a methodological innovation, but also just understand the data sets, that what we can do with them. And I think it's incredibly exciting to see, and this is the first time I've had a progress on this, and it's really exciting to see all the work that's been done, and also the potential, if get all of these aspects to work, and we learn, even if they don't all work perfectly, we're going to learn a huge amount. So any questions, please, for either, David or Tony? You got a mic? Anybody got any questions? Thank you. Now we have only a minute for questions. So a quick question, quick answer, and we'll get 2 questions in.
Brilliant, thank you. So I guess just for a bit of background, I work in public health in a local authority setting specifically. I lead the intelligence team, so the idea of the sort of causal inference, etc. is very exciting to me. I just wonder if you've considered how are you handling time within that?
How we're handling time?
Time, yeah.
Well, that's a good question. Well, we've got a few different things. I mean, COVID obviously sort of like changed a lot of things, and I think the short answer is we're sort of yet to work through that, but I think very much, how these things are changing over time, and is there an interaction there is very much something we're interested in. Do you want to?
Well, the mental health data is a good example, so you can look at that. So I didn't show that same data over time, so you can look at the rise in prevalence over time. And you can also look at differences across birth cohorts, although the birth cohorts get thinner as the population gets a bit older. So, but I think, I guess I've worked a lot on the Danish longitudinal data sets where, that's been the basis for public health action since the 60s, having longitudinal data on the whole population. And a lot of the stuff we do in local authority, we're looking in the rearview mirror, looking at infant mortality rising 5 years ago before we do anything. It's kind of a bit too late.
Thank you. We've got a red flashing light here. Our time is up. So thank you, David. Thank you, Anthony. And you might be around for people to grab, but there was an open invitation there to contact if you want to know more or you want to be involved. So thank you.
Thanks.
So we're moving on now to hear from some of the projects around our emergent public health priorities. So these are things that have come down the track, and we've had some funding available to be able to do some rapid response and get some work up on these on really topical issues or new opportunities for natural experiments. So we've got some quite quick talks, and they're going to do one straight after another, and then we'll have questions and answers afterwards, and we'll do the usual. We'll thank you all at the end. So I think I'm inviting Jenny back onto the stage.
Thank you, and hello again. My name's Jenny. I'm based at Imperial, and I'm going to present on one of the EPHP projects around understanding representations of ultra-processed foods in the media and the public perceptions of them. And of course, starting by thanking and acknowledging all of the work of all the collaborators, both academic and public. So, ultra-processed foods. It's likely, without me really saying any more, that you already probably have an opinion on whether this is an important public health topic. And that's probably been influenced by the really widespread and quite polarized media coverage of this topic that's kind of exploded in the past few years. And as we know that the media can impact agenda setting, and it's also known as a commercial determinant of health, this is really important to examine. So that led to our project, which aimed overall to analyse the representation of ultra-processed foods in the media, the influence of the industry, and how that relates to public perceptions. Now, there are 2 work packages in this overall work, but I'm just going to present on the first one, which is a thematic content analysis of UK newspapers in a year period, 2022 to 23. So we used Factiva to search between the national newspapers and online news, finding 188 articles that met our criteria. I do not have enough time to unpack all of this, so forgive me for being brief, but I'll welcome any questions afterwards. So broadly, guided by framing theory, we identified 5 broad frames across all the articles, and they mainly differed by the extent to which they adopted and really kind of promoted the concept as important, or on the other side kind of critiqued it. They also differed by the types of solutions that they proposed. So on one side you had frames which suggested that government policy action was needed to address ultra-processed foods, and then you had other frames that kind of suggested this wasn't the best approach for policy currently, and alternatively built on that to say that there could be a role for kind of processing and ultra-processing in a healthy food system. The other part of this project was that we analysed the interests of actors who were quoted in these articles, grouping them broadly into 3 groups by whether their interests were linked to the UPF industry or not, or we couldn't identify any kind of interests. There's again a lot to say here, but just to highlight that those who had interests that were related to the UPF industry were more likely to be associated with the frames that kind of were critical of the UPF concept. And interestingly, those actors were more likely to be academics or NGO representatives than directly industry representatives. So it's only about 12% which were industry representatives. So, I got through that in time. Thank you very much, and I will welcome any questions afterwards.
Good afternoon, I'm Neha Jain. I'd like to give you a brief overview of this project entitled The Cost Implications of Ultra-Processed and Less Processed Food Consumption in UK Adults and Children. This is a collaboration between 3 of the SPHR schools, and the PI is Esther Famush from Imperial College. A little bit of background. We know that from the latest data, UK adults eat more than half of their daily energy intake from ultra-processed foods, and our children are eating even more. The umbrella review that just published last year put together 45 pooled analyses with a total of 9 million individuals, and they found convincing evidence that there's an increased risk of cardiometabolic outcomes associated with a higher consumption of ultra-processed foods. Many countries has already acted on ultra-processed foods, such as incorporating in the national dietary guidelines, advising their people to reduce or to avoid ultra-processed food consumption. And some countries have gone even further to introduce regulatory actions. And one of the examples is Brazil. And they've put a cap on their school meals to say that ultra-processed foods cannot go beyond 15% of their school meals. And they've recently lowered that further to 10%. The UK government, the UK right now hasn't really incorporated any of the policy actions specific and my ultra-processed foods, even though the government is well aware of the emerging evidence in this area. There are certainly many things to think about this question, but cost implication is something that we still don't have sufficient data for, and that's the purpose of this project. We would like to quantify, in terms of typical UK diets, what are the cost differences between diets with a higher versus lower consumption of ultra-processed foods. And we will do this analysis separately by adults and children, and also by different socioeconomic groups. And as part of the project, we would like to look at the cost implications. What if we are able to lower ultra-processed food consumption, as well as increase the amount of minimally processed food in our diet, and what would the cost implications be? And our project is also supported by 5 members of the public, and they have been involved and will be involved in every stage of this project. Thanks for listening.
And the clock started. I'm Steve Hope. I'm going to talk about a project that we'll be doing across different organisations within the school, and also including practice and public partners as well. So it involves Imperial, Sheffield, and Northumbria, and also a baby bank, which is a partner we're working with and have been involved in the project all the way throughout, and also Ben Holden, who is a public health consultant in North West London. And what we're doing is we're exploring the impact of family size on child health outcomes and service use. It's a complicated area, and we're taking a mixed methods approach to inform welfare policy, which is why it's so timely. So in terms of just a bit of background to this, poverty, as I think everybody here knows, is related to poorer child outcomes, and there's increasing child poverty in England and Wales, and particularly in larger families. And projections suggest that more than half of families with 3 or more children are going to be in poverty by the year 2027-28. And there's been suggestions and links suggested between government policy and these relationships between family size and outcomes. Particularly 2-child limit, and benefits caps which limit the amount of money that families can receive over a certain number of children that they have, and so obviously it will have a bigger impact on larger families. And so the overarching aim of the project that we're doing is to provide a robust evidence base which includes qualitative and quantitative and engagement work to inform debates about welfare reforms. And we're grounding out the project in lived experiences of parents and carers. That's all of the research from the beginning. We've been engaging with members of the public about and also government departments. So this is just a bit of an overview of how it works. So there's 4 work packages. Work package 1 is PPIE workshops with parents and carers from a baby bank, and it informs research planning and they're reflecting on interim findings that we're producing. There's a rapid systematic review, which is qualitative evidence out there on the impact of 2-child limit and benefits cap on child health. And there's 2 work packages which are quantitative analysis, and they build on some of the things that David was talking about earlier. So the idea of using these large population data sets, so one's in northwest London and then there's one in Wales and one in Liverpool, trying to look at whether we can explore the relationship between household characteristics, including the number of children in the family, and various child outcomes, such as mental health and mental health trajectories, issues to do with tooth decay, respiratory health, and things like that that are recorded in these data sets. And that is my time, and I'm happy to answer questions when we get to the end.
Good afternoon, everyone. I'm here to talk about the Cities of Sanctuary project. I'm Maureen Sagan, one of the co-leads, along with Matt Egan and Daniel Mutanda, but there's a much larger team behind this project. So what motivated us to look at Cities of Sanctuary? So on the 29th of July, 2024, 3 girls were murdered in Southport. Rumors quickly circulated that the attacker was a Muslim asylum seeker. These rumors, as well as pre-existing hostile anti-immigrant and anti-Muslim rhetoric, fueled riots across the UK, starting in Southport on the 30th of July, but quickly spreading to other cities. There were attacks on hotels accommodating asylum seekers by the 31st of July, 2 days after the murders, in Manchester and Aldershot. So we have an image here of such an attack in Rotherham on the 4th of August of that year. Yet anti-immigrant rhetoric continues to be generated, not least by Keir Starmer just last week with his comment that the UK risks becoming an island of strangers to justify clamping down on immigration. But the riots prompted myself and my colleagues to question what can be done to challenge this rhetoric. And it occurred to us that Cities of Sanctuary may represent an organization doing tangible things to combat this negative rhetoric. So what are Cities of Sanctuary? It is a charity which was conceived in 2005 in Sheffield, but has now spread across the UK as shown by the map. Their aim is to make the UK a welcoming place of safety for all. They focus on forcibly displaced persons, including those with refugee status, current and former asylum claimants, as well as those on other visa types, other visa statuses. Despite the naming of cities and the charity name, local authorities can also become cities of sanctuary. Areas must meet various criteria set out by the charity to become accredited, including presenting and implementing a strategy aligned with City of Sanctuary values. So our aim is to assess whether local authorities' Cities of Sanctuary can be evaluated as a public health equity intervention. We have 6 objectives, including reviewing existing evidence on Cities of Sanctuary, assessing whether an impact evaluation is feasible, describing the form and function of Cities of Sanctuary, barriers and facilitators to running these schemes, and sketching out the wider system in which Cities of Sanctuary operate, and finally, identifying the needs of stakeholders in any future evaluation. We will address these 6 objectives through 3 work streams. Work stream 1 consists of a rapid literature review, as well as a quantitative data source review. The second work stream consists of a document analysis of strategies and interviews with implementers. The third work stream involves 2 system mapping workshops with stakeholders, along with 6 focus group discussions with persons seeking sanctuary. And finally, I want to co-opt Keir Starmer's stranger rhetoric by encouraging you to not be a stranger. So here's a list of everyone involved in the project, and please don't hesitate to get in touch to discuss. Thank you.
speakers back onto the stage. So Jenny, Chiara, Steve and Maureen, and thank you all very much. You can see that some of those projects have just started, and I realise those presentations are incredibly brief, but hopefully give you a taste of some of the work that's been done under this programme. So now is your opportunity. We have a whole 3.5 minutes for questions. You'll all be grateful when we finish on time and you can head home. So, question, Anthony.
Thanks. It's a question for Maureen. It's really interesting. I hadn't heard about Cities of Sanctuary before. And did the organisation go through an accreditation process that they make local authorities go through to be counted? And are they doing that strictly, I guess?
Yeah, there is an accreditation process, but to be honest, I don't actually know too many details about the process itself. I know that Daniel Mutanda might have a bit more insight into that if you do run into him, but it's something that we are hoping to kind of get to with the research itself to kind of detail that process a bit more.
Thank you.
Thank you.
Any other questions? There's something about criteria, but also how they're implemented as well, and I know that's something that you're going to be...
Absolutely, yeah.
Yeah, question?
Hi, thanks. Also a question for Maureen. This is coming from somebody who has the misfortune to live in an area where Reform are now in control. I'm curious about to what extent you're able or thinking of bringing in voices of people that do support that rhetoric, because I guess the ideal is to show that for everybody living in a city of sanctuary, things improve, not, including the people that are quite anti-immigration to start with.
That's a really good question. I can commiserate. I also live in a Reform area now. Yeah, I think if memory serves, we are trying to involve areas that are not looking at incorporating cities of sanctuary into their local area. And so we are trying to also get at reasons why people, or I guess local authorities, might not be implementing it. So we are hoping to get at it, but it is going to be a difficult thing to get at. Thank you.
There's a very quick question. It's a yes or a no. Do we know if the cities of sanctuary are getting additional funding?
I don't think so.
No,
But by the project?
No, not well. I don't think that's the question. Actually, I could be wrong. Whoever is asking the question, I think did they get additional government funding to be a city of sanctuary?
I don't believe so, but I can't say 100%.
Okay, I think you're right. Any other questions?
I'm just thinking about some of the legal implication of some of this city of sanctuary, and thinking about somebody who live in Glasgow. If you follow the news around immigration, after the city of stranger announcement by the Prime Minister, the First Minister in Scotland also says something contrary. And in my little years of living in Glasgow, we've had about 2 or 3 cases where the border control is trying to do its job.
Question?
Yeah, so the question is this. How much legality or in terms of involvement are you putting in terms of the opposing voices of some of this city of sanctuary thing in terms of making sure everybody's voices is heard? Because it's not just about...
Okay, thank you. Answer?
Like in terms of the kind of reform voices, for instance?
No, just hearing lots of voices I think is what Latif's asking.
Okay, off the top of my head, I mean, we're doing a variety of interviews with implementers to hopefully capture a variety of, I guess, opinions on how the schemes are implemented. And we are doing 6 focus group discussions with persons seeking sanctuary to hopefully capture some perceptions there. But I'm not sure if that answers your question totally, but we can talk afterwards, perhaps.
Okay.
Sure, thank you.
Okay, thank you. I had questions about ultra-processed food, but I didn't have time to ask those, and time is up, so I'm really sorry. And you all got off the hook really lightly. So I think we'll have to make sure we address that another time. So obviously a lot of interest in all the projects, but I think that City of Sanctuaries has obviously just hit a particular topic of interest. Okay, so thank you all very much. And I'm welcoming Rona back onto the stage to introduce the next session.
So I'm very pleased to introduce our final session of lightning talks. 3 of these are coming from our pre-doctoral research fellows and 1 from a Spark placement. So I will let those folk come up to this. Ooh, I've just pinged this off. How did I manage that? So yeah, the first person to present, which I doubt for me is James, yeah.
Good afternoon, everyone. My name's James Parsonage, and I'm based at the University of Bristol. Cryptocurrencies are a novel technology and encompass thousands of digital currencies designed to offer low-cost, fast, and secure payment globally. Owning and trading cryptocurrencies has become extremely popular in young people and adults, and research has shown associations between cryptocurrency trading and problem gambling. At the same time, we are seeing meaningful increases in young people gambling, coupled with media attention of cryptocurrency trading harms. Through my stakeholder engagement, I've been informed that we are seeing steady and meaningful increases in presentations at gambling clinics with cryptocurrency trading harms, both regionally and nationally. So what's the underlying theory here? Well, individuals owning cryptocurrency can trade this in a volatile market environment and engage with other ways to earn cryptocurrency, such as Web3 games. Individuals may experience different levels of gambling or gambling-like behaviors through 1, riskier trading behavior, 2, utilizing cryptocurrency's global, seamless, and less regulated gambling infrastructure, and thirdly, through increased engagement in wider non-cryptocurrency-based gambling. This may lead to gambling-related harms. And all of these interactions may be driven by commercial actors, social media influencers, government regulation, public health strategies, and support service provision. So here, focusing purely on the qualitative element of my work, my plan is to, while working with young adults, young adult advisors and health ambassadors from minoritized communities through AfRIs Health, to recruit a diverse group of young adults with lived experience of cryptocurrency trading and gambling behaviors, and to understand timelines and trajectories of their behavior before and after the age of 18. Their coping strategies will also be explored and synthesized in co-developed creative communications for young adults and young people. And focus groups with young adults, parents, gambling harm stakeholders will synthesize and co-develop action plans of their priorities, which will be voiced through policy briefings to key influential stakeholders. Thank you for listening, and I will be glad to speak to you, so please do come and say hello.
Good afternoon, everyone. My name's Neha, and I'm here to talk about how I've been, over the past year, how I've been leveraging my fellowship to speak about, to look at policy-driven actions for promoting oral health. So why oral health? And that's the first question. Oral health has been widely neglected. It is one of the most prevalent conditions and exists in the form of dental caries, missing teeth, poor and periodontal diseases, all of which have been connected with poor nutrition, frailty, and also overall poor well-being and poor quality of life. So essentially, there's a lot of oral health inequalities that exist, with children from lower socioeconomic backgrounds facing up to 10 to 13 or 18% higher prevalence of dental caries as compared to anybody from a higher socioeconomic group. So I really was very interested to see there are a lot of policies and programs about that target the common risk factors for oral health, namely tobacco, diet, and excessive use of alcohol. And so I really wanted to see, and I'm really interested to find out how these policies and programs through the means of common risk factors have also been targeting oral health. So I started on this fellowship. Now, by the nature of the pre-doctoral fellowship, it's supposed to be very exploratory. And I quickly found out that there is a very fine line between me being explorative and me being just confused and unclear. So I started on a lot of conversations as part of this fellowship. I spoke to a lot of different people. And basically, it led to, I've tried to bring that down to 4 or 5 different aspects throughout the last year, which includes collaborative research, public involvement and engagement, placement in training and capacity, all of which I'm hoping leads me to a doctoral fellowship or an application for the same next year. A lot of these conversations I was able to have with the Gateshead HDRCs, and we realized a lot of common grounds. I was able to, using those connections, I was able to apply for the ResNet Award, and I was recently awarded £26,000 to look at oral health support in family hubs. There's more information about this study on my poster, which is on display currently. I took this through this project. I've been speaking to a lot of parents, and I've been speaking to a lot of members in the members who are running family hubs to be able to build those networks, understand what is important, and sort of help contextualize my research questions for the doctoral fellowship. All of these conversations made me understand in a lot more detail about how local authorities, not completely, but get a good idea of how local authorities work. I know what HDRCs mean finally. But I've been speaking with them, and I've been able to leverage that and get a placement with Newcastle City Council that I soon start. But all of this has mostly been about training and capacity building my entire fellowship, and I'll be quick. But I've been able to get some more funding to get an intern to build my leadership skills as well. I wish I had a conclusion slide now more than ever, but I don't. But I'd like to end by thanking my supervisors and my mentors who've helped me put all these ideas from a phase of unclarity to some actions. Thank you.
Hi, I'm Kat Jackson. I'm a pre-doc fellow at University of Liverpool with Lilac. I've got a master's in public health, but my background's actually in project management. So becoming a fellow has been a completely different journey for me, with the main goal of gaining more experience in different research methods. I started in March last year, and I've been immersed within research, carrying out a service mapping exercise with the Food, Pregnancy and Me programme. I've done qualitative interviews with the Mandela project, looking at Birmingham City's emergency food response, and I'm currently undergoing a research placement at Knowsley Council, looking at their food aid provision. I've just been awarded a ResNet award, looking at how Household Support Fund is being used to support families with children in deprived areas. And that's what I'll talk a little bit about for 2 minutes. So food insecurity, as shown there, can be defined as being unable to acquire an adequate food source for one or more household members due to having insufficient money. We know it's a growing concern. We know that increases health inequalities, and we know that areas of deprivation suffer more with it. The Family Resources Survey last year revealed shockingly that every month 10% of households in the UK experience food insecurity. More concerning is that it disproportionately impacts certain groups, such as families with children and single-parent families. The Household Support Fund is one of the government's initiatives to support people struggling with food insecurity and other essential costs, such as water and energy bills. It was introduced in 2021 during COVID, and it's distributed by the Department for Work and Pensions, but each local authority uses it differently. But this flexibility has led to a variety of approaches by the local authorities. For example, Manchester uses 50% of its funding to give people direct cash awards, whereas Blackpool gives zero cash awards, preferring to spend money on third-party support services. So every local authority is using a different approach. So this research is a mixed methods project, and it's focusing on 4 local authorities: Knowsley, Blackpool, Manchester and Liverpool. And they've been chosen due to high deprivation levels, but also their diverse approaches to using the household support funding. It's in 3 parts. Firstly, analysing the national data to identify the key trends and differences on how funding is allocated to food insecure families. Secondly, I'll be developing case studies of the 4 areas to explore the range of interventions funded. And lastly, but not leastly, explore the lived experience of families who may or may not be accessing the support. Do they know it exists? Is it reaching the people? Is it making a difference? And I've got 4 public advisors within each area to support me with that, who are co-researchers. So currently there's a lack of in-depth research of how this funding can be used at a local level, but I'm hoping that this project will better inform support strategies and create a body of evidence of how the funding can be used more effectively, informed by lived experience. Thank you.
Brilliant. Hi there, so I'm Zoe Clarke. I'm a pre-doctoral fellow at the University of Sheffield, and my background is working in public health practice, and I very much see myself as an applied public health practitioner researcher. I want to tell you about 2 projects that I've done with Sheffield City Council as part of my pre-doctoral fellowship. So the first was working with medical students. At Sheffield, all medical students in their second year have to do a research attachment. And I'd just been to summer school in Denmark, which was very nice. And I was learning about healthy cities. And I was really interested in what the Gale architecture firm do, where they observe what people actually do in the city to be able to design city infrastructure that supports health. And I wondered, what could we do locally? So with Liddy's, my supervisor's support, we worked with 8 medical students to look at how hot food takeaways were used around schools in Sheffield. So Sheffield City Council were producing a policy on hot food takeaways, and the students went out and collected observational data, seeing how the young people used the hot food takeaways at lunchtime and after school. And they collected various data like how, what kind of takeaways they saw. They found more hot food takeaways around deprived areas, unsurprisingly, and they felt that the hot food takeaway policy would only have limited impact because they observed young people getting junk food from a variety of different outlets, including convenience stores and corner shops. My second project is my ResNet-funded project, which I have a poster outside, but I'm going to take it down very shortly, so you've missed your opportunity to see all the information on that. And this is, again, working with Sheffield City Council. So I'm going to be working with residents in Sheffield to find plain and accessible language around the commercial determinants of health. Sheffield City Council have enacted a number of policies to address the commercial determinants of health, and they have a public health practitioner whose role is dedicated to that area, including their food strategy that I talked about before, gambling strategy, and an advertising strategy. They want to be able to talk to their residents about this work, but they don't have language that's accessible to be able to do this. So this work will directly impact their communication strategy. We're going to use deliberative methods where we teach residents about the commercial determinants of health through different activities and then ask them their own words to describe what we've just taught them. We'll help to find consensus on language, and then we'll use this to inform not only local strategy, but we're hoping it will be useful for national people working in the field. Thank you.
Great. So, questions from the floor? Yes, Rowan.
Hi, my question's for James. So I just wanted to know a little bit more about the population characteristics that you're working with in your study about gambling harms from crypto. What kind of information do you have at the moment about who's being affected by this? Because you mentioned that you were going to specifically work with some people from marginalized communities, or I'm not quite sure exactly the wording that you used, but I'd love to know a little bit more about how you came to have that information and what you know about who is being affected by this.
So a really good question. I think what's clear from the literature is that this is potentially more likely to occur in more affluent white males. However, research on gambling suggests that even those in minoritized communities may be less likely to engage in gambling, but may be more likely to suffer from harms. And therefore, I do not want to just simply engage with those that seem to be more likely to be engaging in cryptocurrency, but to begin to investigate the potential for harms occurring in communities outside of that.
Great.
Thank you. I'd like to ask Kat a question on your choice of Liverpool, Blackpool, Knowsley and Manchester in terms of, I mean, obviously you've got a coastal town. I mean, Manchester and Liverpool, are deprived in areas but affluent in other areas.
Yeah, so it's based on the indices and multiple deprivation, which by chance and unfortunately the top 4 are all in the northwest. So it's also based on the use of the household support fund as well, which are all very different. So I think it makes a nice study to look at the different approaches. The public partners, I couldn't mention on there in the short time, but that's gone really well. So I've got Blackpool HDRC on board, who were really eager to get involved. I've also got ARC Northwest, who are a partner as well. So we've got a lot of collaboration with the public, and the organisations have got Resolve, Poverty, and a few other local area-based charities that are involved on the study. So I feel like we've got good connections there with a lot of the communities.
Thank you. Great. Other questions in the room or anything on Slido? Nothing on Slido. Okay, I'm going to use... actually, you go first because mine's
I guess, Neha, just for you in terms of oral health, and we have had work in the school around oral health in the past, but it's great to have that, and obviously you've got the ResNet. Why do you think that oral health, you said it's a neglected area, why?
So, historically speaking, it also stems from the fact that, and this is something that I learned during my master's years ago, and I still remember to this date, there's no mortality associated with oral health, which generally makes it a less I wouldn't say research topic, but people tend to take it a lot less seriously. What they don't understand is, while it's not linked with mortality, it is still linked with poor quality of life and poor well-being, and that's where it really needs to be focused on, and that's what I keep thinking about.
Okay, so our time is up, but I just wanted to make an observation, which is that 3 of our pre-doctoral fellows have all got ResNet awards, which is amazing, and I happen to know that James is actually very involved in another one. So congratulations to all of you, and I think that that's really well done.
Right, well, we're going to move on to our 4th and last research programme. Very important area that cuts across all of our work, and that's the Health Inequalities programme. And Judy Green is here to introduce to us, and then after there's been some presentations, we'll have a Q&A. Thanks, Judy.
Thanks very much, Hi, Marnie. And this is the best of slots and the worst of slots, isn't it? It's kind of the end of the second day, everyone's flagging a bit. But the good thing is, it's not a good thing, but we've heard so much about health inequalities over the past 2 days, and some of the shocking, not just lack of progress, but going backwards on indices of health inequalities. I probably don't have to say much about the background to the programme. I'll introduce myself. I'm Judy Green, for those I haven't met. I'm one of the co-leads, along with Emma Halliday, who's here. I've been very remiss in not putting the rest of the team on the slide, so this is probably the opportunity to say huge thanks to our predecessors as co-leads, Claire Bamborough and Jenny Popey, who've done all the hard work, so we just come in at the end when they've set everything up, which is rather nice. Also, thanks to our project researchers, Rebecca Mead and Viviana Albany, who we'll hear from in a moment about her own project. And a huge thanks to our PPI, the programme leads for the PPI, Alan Griffiths and Rod Leiper, who've been fantastic input throughout the programme. So, next. I'm not going to spend ages introducing the programme, just to flag up a few of the objectives that we've got, because you may be thinking, given that health inequalities is something that's in almost every, I think it should be in every project that's funded by the school, so we're all addressing health inequalities. What's particular about the projects that are happening within this programme? There are a number of things. Obviously, as a programme, we're trying to think across the piece around some of the knottier issues that get thrown up when we're not just researching inequalities, but also thinking a bit about how we evaluate policies at a structural level that are aiming to address health inequalities at a time when I think one of the last speakers flagged, given the causes of those health inequalities are austerity, rising levels of poverty. What is it that we're doing as health researchers in public health more generally to try and address those at a structural level? So we're trying to take a step up. I've put the objectives of the programme up there. I'm not going to go through them all, but I do want to just flag a couple of them around looking at innovative methods for trying to fold in a whole range of different stakeholders in the system and what their perspectives are on the kinds of things that matter to them, and what we're measuring, and an approach that's around intersectionality and co-production. If I just flag up the projects that have been funded under the phase 2 of this programme, we're going to have very short, you'll be pleased to know, talks about 3 of those. Those are the ones I've put in bold, but just to say something very brief about the 5 projects that have now they are now underway. And they are trying to address those objectives that are flagged on the last slide. So we've got Clarity Plus, that's about collective reimagining of community-led public health evaluation from the perspective of racially minoritized communities, and that's the one we're going to hear about first. We've got Belong, which is about belonging and difference for people with learning disabilities. Create, which is about co-creating spaces of belonging and safety for marginalised communities. Systems, which is a project that's looking at how local public health systems interact with policy initiatives that are addressing social and health inequalities, and that's a project that's looking towards trying to evaluate not just particular interventions, but the kinds of local systems that are or are not associated with narrowing inequalities in the longer term. And then finally, growth, that we'll also hear about in a moment, which is health inequality, looking at the impact on health inequalities of national policies that promote local economic growth in disadvantaged places. Just to say, the only other thing I want to say before I introduce the speakers is just to say something on what we're trying to do as a programme that's over and above just creating more evidence on health inequalities and more small evaluations of what might or might not work. And one of the things that we've been grappling with, and I think it has been flagged up by a number of the speakers over the past 2 days, is that when we talk about health inequalities, we're talking about rather different things often. We're using lots of very different conceptual and pragmatic models of what we mean by an inequality. Do we mean exclusion of some very marginalised communities? Do we mean something about the gradient? Do we mean something about the absolute differences between the top and the bottom? So there are differences in conceptual terms about what we mean by inequalities. And there's also something around, which I think we're often really bad in public health at acknowledging, which is the trade-offs between the different kinds of equity outcomes that we're interested in. And we've heard a few of those flagged over the last 2 days, where Chris Bonnell, for instance, talked in schools about the kinds of interventions that might ratchet up achievement and attainment for children that might work at that level, unfortunately might also have some costs in terms of the kind of belonging that happens in schools. So one of the things as a programme we're trying to do to try and think through, well, what do we mean by different kinds of equity, the different kinds of outcomes that different actors in the system might be prioritising, is to try and capture some of those different sorts of outcomes, and how can we best evaluate policy in ways that really fold in what's important to different stakeholders, and ensure that we really are measuring what matters, and that we're also attentive to some extent, not just to the intersectional ways that inequities build up, but also, unfortunately, to some of the trade-offs that might happen across the piece. So that's all I'm going to say by way of background. I'm now going to hand over to Rahila Sheikh and Aisha Sheikh, who are going to introduce the Clarity Plus project. Over to you two.
Hello everyone, my name is Aisha and I am community organization partner with this project, Clarity Project, and I'm one of the community out of 17 communities, and we have 10 communities from Sheffield, 4 from Coventry and 3 from Birmingham. So I'm from Birmingham representing UKIM organization, and it's a faith-based social organization, and we work with different communities, community groups and different age groups, and also some marginalized groups such as homeless and asylum seeker as well. And for me being in my contribution to the community for 7 years, so first time I've been invited for such a project, and I'm very happy to be part of this project. And Rahila is going to explain more about what's been going on. Thank you very much.
Thank you, Aisha. Thank you so much. She just want to get rid of me. So she just said, Rahila, let me go. I said, okay, go on. I'm just saying that this unprecedented pressure of time has erased all the data related with the humor, so I left with my slides only. So be with me. I don't mind if you want to sleep. Okay, so as Aisha has introduced us very beautifully, so we are the Clarity Project here, and my beautiful team members are sitting there. So don't worry about the questions. I leave them with you. So we started this project 2023. It's a very lovely and beautiful journey, I could say that. While doing the PhD, I have dreamed about something, and when I got this project, I was very excited. How come the dreams can come true so miraculously? And this is the project which I want to say that, as Judy said, that health inequality, we all know we all are working on the different areas of health inequality. We know that the health inequality among ethnic minority, there are the different determinants related with the poor health. So what is different in this project apart from, we all know that there's something bad going on with ethnic minority or health inequality. There's something which is poor. So what we did in this project is something very positive rather than the traditional approach about the something poor. So the health inequalities is, when we talk about the health inequality, let me read first thing this. So the goal of this Clarity Plus project, which we started in 2024, the first one which we did, the phase 1 was the Clarity, which we finished in 2023, where we have created a positive relationship with this 17 community organization. In our second phase, we have a goal to co-develop and pilot the community-led approaches, evaluating community-based action on health inequality facing racially minoritized community. This is something very positive, and I really have a passion for this project, because I thought, oh, this is something we want to know that, because we know that the community is all about community organization, and I excuse myself to use the term the community organization. we are different from the lots of other projects because we use the term community settings, so we don't have the very traditional community organizations such as the faith organizations, some are the social organization. We have also involved some unofficial groups in our project which don't have a kind of a very official setting, who meet regularly, maybe the monthly basis, sometime weekly basis. They don't have website, they don't have the setting where they go regularly and meet and talk to each other. So we have involved them as well in this project. So we are trying to reach the grassroots of the community. We did not restrict it ourselves. I know it was a bit challenging in terms of the funding and other stuff, but we were very happy and we are very positive that we have reached the grassroots of the community. So we are not just taking the superficial layer of the community who is going to the community organization, because not all the people get the time to join the community organization. So we need to find this other ways or innovative approaches. Okay. So we are in a journey of developing the innovative ways of the community-led approaches to evaluation. So when we have started the first year, so we have found that there are lots of work done by the community organization which has not been recognized. So in our first year, we have very beautifully developed a positive relationship with all of our 17 community organizations. And they were so happy, as Aisha has said that earlier, that we are not the typical researchers going and collecting the information or data and then we are going to publish something. We were asking them what exactly they want from us as researchers, and we were so happy to find that the community organizations, the term community-led approaches, they are doing very well. They are working with the different constraints of public health independently without involving any professionals or academic or the researcher. So we have come up with this idea along with our community researchers to create evaluation tools which can be used for assessing the community-led health approaches. And these are the beautiful pictures from, we also have, 17, we are doing the 17 showcase events in this project. We already did the 4 showcase events where the communities are coming together, and we involve the other policymakers and the city councils as well, where the community organizations share their experiences, how they are working on the different constraints of public health. Till now, we did the 4 showcase events in the different parts of Sheffield, and next one is in the Birmingham. And I love this term, which is called as apart from our project, we are also sharing the knowledge between the stakeholder, and I love to say that it's an organic growth. So over the period of last 2 years, I'm so excited, I'm so passionate, and also my other colleagues. So we are not only focusing on our project, but we are also trying to help the other academic and the researchers. So most of the time when we go for doing the presentations to the city council, we did some presentations in the city council, different poster presentation in different conferences, and the people are happy and listening to us, and they want to know that how to create a positive relationship with the different community organization, and how to overcome the barrier in accessing the different community organization. And I love this part, that we are not only just doing our own project, and we are just not focusing on publication, what we are doing, but we are also helping the other academics and the researchers. Hopefully I'm on the time. Okay, in the next step, we are going, as I said that, we have planned to have the more showcase event in coming years, yeah. Even for the funders and organization, which we have planned for the July, and hopefully we'll have a very successful event in terms of listening to the other people as well. We are going to collate an example of funders monitoring the evaluation requirement. For example, the National Lottery Council funding, Sports England, ICB funding. This is one interesting thing in our project is that we have the traditional and non-traditional organizations. So traditional organizations are well aware of the term evaluation. When it comes to the term evaluation, they are well aware because they get the funding from the different sources. But when it comes to some non-traditional organizations who are working on the health determinant, but they never come across the term evaluation, So we are also going to have something which is called the peer support. So we are trying to link up our traditional organization with non-traditional organization where they both can share their experiences. If somebody is doing evaluation, why they are doing evaluation, and if there are other people who are not doing evaluation, they want to explore the more option, why it is important to do the evaluation if they are doing something. And I think it's very important because all the community organizations are a very important public health asset, especially in terms of the health. They are covering all the determinants of the health. If they know what's work and what does not work with them, it will help us as a researcher in future and also them to apply for the funding so they can be supported in future for the long-term impact. And we are going to design and pilot the phase where hopefully very soon we are in the steps of writing down the assessment, rapid assessment for the publication, but because due to the lack of literature, we are just in the conversation, we are going with this type of what you call the publication, maybe the commentary rather than a traditional assessment, because there's not enough literature available on this area, the evaluation by the community organization for their own health-led initiatives. I think that's it from. Okay, that's it. Thank God it's last one. Yes, so here is our contact information. Just one last thing. While doing this project last year, we have also got the added funding from the Warwick, which is called the place-based funding. And we have created a very beautiful website, which is called the West Midland Knowledge for Action and Partnership, and where we have an interactive map where we are trying to collect all the information regarding the different community settings around the UK. So being a researcher, being an academic, even if you're a community organization, you want to see what's happening around the what you call the public health field. So we are keep updating the people on that website. So I would really appreciate if you can join our website. And these are our email addresses. If anyone interested, if anyone thinks that they have some idea they can share with us, more than welcome. Thank you so much.
Thanks, Rahina. So that's one example of one of the projects that's really looking at community-led approaches to evaluation for interventions. The next short presentation is pre-recorded, and Poppy Budworth has led on pulling this short presentation together on the Belonging Project. So you're going to press play, yes? Thank you.
Hi everyone, my name is Dr. Kate Sykes, and with my colleague Poppy we have developed this pre-recording presentation which is going to show you our progress of the Belonging Project, but also share with you our methods, training and early reflections so far. And to start, we need to think around how belonging and health link together, and ultimately it becomes one of the social determinants of well-being is that sense of community connectedness and belonging. So we need to explore how and where people feel that they belong, to really understand how different groups of people access the community and feel connected and feel safe and feel at home. As a brief overview of our project, we are a team of 6 academics and 6 peer researchers, and we are all training and learning together in this project. So we go through everything together. We have co-produced this study from the previous knowledge partnership work that was completed, and now moving forward we are conducting research. So how does belonging link to health inequality? So what we're going to do is 3 main things as part of our project. We're going to use crafts to help people explain what belonging means to them. We are then going to have a focus group discussion to really go into more detail about belonging and health. And then our participants can take part in an optional walking interview. And a core principle of what we've been doing on our project is learning together. So to date, we've conducted multiple sessions such as how to develop a research question, how to co-facilitate focus groups on ethics, how to be a good ally. And what we're thinking about doing moving forward is having future training on how to analyse research data together. And the image.
So here we have a quote from Siraj, who's one of the peer researchers in our team. He's reflecting on how he found the co-facilitation training with Paradigm, which took place at the end of last year. As you'll see, Paradigm created a very comfortable and open space for us to learn together as a team of people with and without learning disabilities, while sharing essential knowledge and skills about how to conduct focus groups about belonging and health. In terms of early findings related to health inequalities, we have found that place significantly shaped one participant's experience of belonging and their health. Here is a quote from the participant in his 70s, who identifies as a gay man with a learning disability. Al shared that he'd moved to Brighton in his 50s from another area in England. Al explained that he'd moved to feel safe and because you can be what you are in Brighton. I understood this to mean that Al felt safer and like he could be himself as a gay man since moving to this area. Al also explained that his health was getting bad where he previously lived, as a result of not having access to these things and feelings. So this came from my fieldwork reflections after the focus group. On this slide, I've also included the artwork that Al made during the focus group, with different parts of the artwork representing different parts of his life that bring him joy and help him feel like he belongs. For example, particular music artists and LGBTQI+ music venues in the area that he lives. As a team, we continually reflect on how things go, so what went well and what we can learn. Here is a quote from one of the peer researchers on our team, Matty, who conducted a focus group with me in March with LGBTQI+ people with learning disabilities. Matty was a brilliant co-facilitator, and he equally found the experience rewarding and interesting, as you can see in his quote on the screen. So in terms of our future plan, we're going to continue with data collection and analyse our findings together as a team. We will consider how our findings advance work on health inequalities, focusing on belonging as a key factor in this. We will continue to work with our advisory group, and we will share our findings through impacts and engagement workshops, as well as create accessible and community-oriented outputs. Thanks everyone for listening to Kate and I's presentation today about the Belonging Project. To learn more about our work, you can visit the SPHR website, or you can email myself or Magdalena, and our email address is on the screen.
Thanks very much, Kate and Poppy. And that's an example of a project that's looking at how we really do think about belonging across those intersectional axes of inequality. So our final presentation is behind me. Viviana Albany. I was going, where's she gone? She's escaped. But she hasn't. Viviana, can I hand over to you, please?
Sorry about that. Apologies if I speak a bit fast, as I have lots of slides. So this is the long title of our project. We're looking to research the health inequality impacts of national policies aiming to promote local economic growth in disadvantaged places, and we just call it growth. And our team has members across Fuse, Lilac, and Sheffield. So a few motivating... Before I start talking about our research, just to clarify what we mean by national policies to promote local economic growth. And this is a specific type of policy called place-based policies, which are policies that have direct transfers from national governments to subnational entities responsible for local development. And these policies tend to target areas, and in many cases, disadvantaged areas. So motivating facts for this type of policies, well, they are important policies in the UK and in other countries. They may not be the best policy. There's a lot of debate if they're the best way of achieving regional convergence in economic growth, but for a series of reasons, they're unlikely to be abandoned by government. But the nature of the work they do, they target social determinants of health, so they have potential to be a tool to addressing health inequalities, and they have an inherent equity dimension to them in that they aim to lift areas that are lagging behind in economic growth. For our specific project, we are focusing on 6 local growth funds as a type of place-based policy. A recent example is the Leveling Up Funds, but we are going to look at these 6 previous funds to the Leveling Up Fund. And we have collected data for these funds through Freedom of Information requests and online searches of the individual projects that we're funding for each fund, how much money got the project, where the project took place, and where appropriate at postcode level, and the timelines. So we're hoping to build a data set at a neighborhood level about this, the amount of local growth funding that has gone into a place and different types of projects that have taken place. And the idea is to compare well-being and other health impacts, places that received funding, that haven't received funding, and also, as I said before, different types of projects funded. But key piece of the work that we are doing in this research is also understanding how these local growth fundings can impact health inequalities. So to answer this question, we went back to the economics literature to see how they see place-based policies as an instrument to reduce regional economic inequalities. And so from reading that literature, we realized that we quickly needed to understand what is it that place-based policies really seek to do, because there's so many different types. And at a broad level, what they want to do is that correct an imbalance in where economic activity locates. Basically, if you leave it on its own, there will be a kind of inertia that results in places that are big economically getting bigger and bigger, and places that are lagging behind getting stuck in poverty traps that are difficult to break. So these place-based policies, they use investment in different levels of economic growth to try to break those poverty trap cycles. And this is the key bit that we find common across all place-based policies, is that what they really want to do is generate jobs in an area, attract private investments, so companies that move into an area. And crucially, they try to make this new investment productive, so companies that are highly productive, and jobs that are better paying from people that are highly skilled. So in terms of the logic model for how place-based funding might influence, in this case, well-being. So when we looked at what's had been done before, we found this logic model for the Leveling Up Fund. And we said, oh, wow, fantastic, someone's done a work for us. And it's even pretty, you know? And then we realized, so if you look at the logic model, there's all the inputs from the funds, which is basically the money that's being invested, the activities that take place, and then the direct effects, which are the physical changes that come with the place-based investment. So in this example, it's about releasing land so people can build retail parks or industrial parks or homes. And then there are the indirect effects, which is what the place-based policies are aiming to change, and is what happens when companies and people move into an area thanks to the incentives put in place by the place-based policies. And we thought, okay, fantastic, this logic model is great, but if you look more carefully, this logic model doesn't say much about inequalities that may arise from this type of investment in local areas. It does mention net effects, and that got us thinking, what are these net effects? Who's losing? Who's winning from this type of funding? And so we went again back to findings and the literature, and we realized that there are distributional effects to place-based policies. So some of them are well documented, which is displacement effects, which is the graphic at the end, where what happens to an area that neighbors another area that got place-based policy, place-based funding, but they don't. So what happens? So typically what happens is that they lose people or they lose companies. And so basically they become more impoverished in a way. But there's also a lot of debate around, do place-based policies really help the people in the local economy they're meant to be helping? And so you might have effects across the distribution of jobs and our income within an area. So this is getting us to think about the logic models for our work, and this is very much work in progress. So how might this translate to health inequality? So you might find, you think about differences between areas, like displacement effects. So what happens to an area that's losing human capital from these displacement effects? But you might also find within area inequality effects that are less discussed when people talk about place-based policies. And so this is the type of logic models that we are structuring that are trying to capture that. So what groups within these net effects, so who are the groups that are gaining or losing, or to what extent both gaining? And so this is an example of what the typical place-based funding seeks to do. So they seek to attract new residents with higher skills, which means higher wages, and through a series of multiplier and productivity effects, these new residents with higher skills have higher wages, but they also start demanding from the local economy services. So in the local economy, you increase the probability of employment of local residents. But then there's a question, what's the quality of that job that's being created? And there's some evidence that some of that may be in very low-paying jobs or in insecure jobs. But overall, there may be an increase in the wages in the local economy, which would benefit everybody generally. But then, because there are higher wages, there are going to be also higher prices of things, which are called general equilibrium effects in economics. And so this might have implications for real income, and then that real income will then have implication for your well-being effects. And the yellow panel is showing one of those, the results of those kind of sorting effects. So if your local neighborhood becomes too expensive for you, you have to move out. So you, again, might face well-being effects from a place-based policy. So very much these are the type of models we are developing. And this is like the most generic one that, if you notice, it's only capturing as pathways to the outcome, wages and employment. But of course, place-based policies might have other ways in which they impact health and well-being. So you might think of investment in active travel routes and what that will do to air pollution and so on. So we're going to continue this work about a logic model, about our theories of change, thinking about other direct effects, and thinking about different types of place-based policies. So, and also, crucially, taking this to our public and our practice partners so we can validate and enrich what we are finding. Thank you.
Hi there, I'm Emma Halliday, one of the co-leads. I'm just going to take over for the final couple of minutes for questions. Is it, I think, are we going straight to the floor for questions? Yeah, brilliant.
So my question's for the Clarity Plus team. I really enjoyed hearing a bit about your community-led approaches to evaluation. And I wanted to just ask if you could maybe talk a little bit more about that if you wanted to. I'm really interested in this strengths-based approach, like focusing on the positive aspects. And I wanted to really know if there was anything that you felt worked particularly well, or that you might want to change for next time?
Sorry, can you please repeat it?
Sorry, so when you were working with the community groups, when you guys were developing your methods of evaluation with the community, what worked really well?
Okay, thank you so much. If I'm understanding it correct, at the moment we are just in our second year where we are doing the showcase event, and we are trying to make an evaluation tools, and we are going to do it a pilot, hopefully by next year, Steph? I'm asking Steph. So hopefully by next year. So what works in terms of, do you mean that when we are connecting with the community organizations? What approaches to evaluation? I think we are not at that stage yet. We are just still in the process when we are going to create a tools for the evaluation. At this stage, we are just in a conversation with the community organizations. And as we said that we are trying to connect the people who already have experience of evaluating the research in their own settings, connecting them with the people who never had an experience of evaluating anything, if that makes sense. Thank you so much.
Hi, thank you, all those really great presentations. My question is for Viviana. I was just thinking, Viviana, in your logic model, you're talking at the end about direct effects, and there may well be indirect effects. I was thinking things like social cohesion, for example, and impacts on community engagement, and I think social cohesion in particular. Is that something you might consider?
So, sorry, I didn't explain myself too well. So, the framework that through which we're approaching this thinking uses direct effects to think about physical changes that come from place-based investment. So you might find a new university, for example. Whereas the indirect effects, it refers more to this relocation of people and capital, which means companies in a place. So it's really the response of individuals and companies to the incentives of come and set up shop here, which we have all these set up for you, and you're gonna do really well. But channels that, so that channel really focuses on the wage and employment indirect effects to well-being, but there are other channels through which place-based policies might influence health outcomes. So, for example, in the example logic model of the Leveling Up Fund, they talk about civic pride in an area that has been recovered, for example, and I don't know if we'll be able to capture that quantitatively, but yeah, we are aware that are also mechanisms through which you can expect results. Thank you.
Any more questions? We've got time for one more.
Yeah, very briefly. In terms of the place-based policies, we've seen some policies, especially in this country, that were only announced. So the policies you are looking at, are you considering those that were actually implemented, or those were just announcement effects like Leveling Up, for example?
No, we are using historical data precisely because of that. When we were preparing for this project, we realized Leveling Up funding hasn't reached the ground in many instances. So yeah, we have data on the actual amount that was awarded and amount that was spent. Yeah, we're focusing on spent, yeah.
Can we thank all of the Health Inequalities programme, please? Thank you. Okay. Okay, so we're moving on to the final stages of the afternoon, and I'd like to welcome Rona Campbell back onto the stage while we do recognise some of our trainees and some of the excellent work that's been presented over the last couple of days. Rona.
Thanks very much. So first of all, I'd just like to thank everyone who was involved in creating all of the wonderful work that we've looked at by our early career researchers, and also our judges. You gave us an incredibly hard time because the standard of presentation has been so high, and it almost felt invidious to have to judge such excellent work, but we have done that. And so, because that's what we were charged with doing by Andy, and of course we have to do what Andy says. It is my pleasure now to announce the prizes, and in traditional terms I'm going to start first of all with the posters, and we have a specially commended award for Sophie Dark, if Sophie's still here. We're going to take it for... Oh, sorry, you've come on that side. Yeah, so we might need to switch. And the next award is runner-up for the posters, and that goes to Kaya Hurley. Yes, she is. Congratulations, Kaya. And the winner of the poster category is Neha Jain. Well done, Neha. That's great. Okay, so moving on then to our fabulous digital stories. We have two runners-up in this category. The first is Lauren Cross. Is Lauren still here? Yes, she is. Thank you for your wonderful animation. There you go. Thank you. Congratulations. Well done. And the second runner-up is Irena Tetkovic. Irena's doing well. We're doing well. Is Irena still here? No, I think
we'll give it to you, Esther.
Yeah, we'll give it to you, Esther. Yeah. And the winner in this digital stories category is Jax Bennett. Yes. And yes, I think we have to say that was a joint prize for Jax and her daughter. Okay, so our final category then is the lightning talks, and the runner-up here is Rosalind Arnold. Job getting these out of the... Okay, let's hold it. Congratulations. And the winner of the Lightning Talks category is Devara Bennett. Congratulations, Devara. Okay.
Wow. So after all of that excitement, it just leaves me to do a few closing remarks and to hopefully send you all on your way feeling like you've spent the last 2 days learning lots, making some new friends, meeting some old friends, and generally having a really great and productive meeting. So first of all, I'm going to start with some thanks. Our annual scientific meeting is always the highlight of the year. It's a time, the only time we all come together. We meet in different times, but we all come together for this. But it doesn't just happen. So I want to start by thanking our ASM Planning Committee, chaired by Rona Campbell and Matt Egan, and all of the people that were involved in all of that planning. So I want to thank them, and I'm going to ask us, we'll give them all a massive round of applause when we're finished. I want to thank the Bristol SPHR members for hosting. And perhaps a particular shout out to Sophie Bacon, if Sophie is here, because Sophie was involved in scoping out and working with the team for Bristol in 2020, and then had to do it all again 5 years later. But here we are, and thank you to Sophie. I want to thank the hotel for feeding and watering us and looking after us, and also to everybody across the Bristol team and others that have hosted the walks and the runs and made sure that we had some activity and actually saw some of the lovely city of Bristol. I would like to thank Beacon House and to Katie and Chris, who've kept us all on time, but also made sure we got here and we all knew where we were going and who was doing what when and everything else. So thank you, Katie. Thank you, Chris. And also to dealing with the challenges of where you put a mic when somebody's wearing a dress. That's the kind of thing that they have to think about. I want to thank particularly some of our the public and community partners that have attended today and yesterday and contributed to the ResNet. You're a really, really important part of our wider school community, and your contribution is massively valued. So thank you very much all for being here. The Directorate is always very much involved in the planning in terms of organising the committee, but everything else, developing of the programme, all of the full details of the programme, putting it all together, promoting it, making sure you register, reminding you that you're coming, and all of that. So I think Amy, Andy with the trainees, Laura Fennick, Michelle Wilson-Chalmers, I think particularly I just want to thank Susan, who keeps us all right and also makes sure that we're all here in the right place at the right time. We've had some colleagues from Department of Health and Social Care joining us all day yesterday. We had Jane Barrett, and today we've got Ollie Brown. So thank you to yourself and to Jane, not just for being here today, but also for the massive support that you give to the school in the interim. We've also had some administrators joining us over the last couple of days, people who are back at the membership and also do all of the things that you've seen, all the research being presented, you've seen all of the projects being presented, but behind all of that is all of the work about making sure you actually get your money, you actually get your contracts and all of those things. And that's a real partnership between all of the administrators back with each member who work really hard and work really hard with the Directorate and with Susan, and are a fantastic team that sort of are under the radar and you don't see it happen. And I think we should make a moment to just thank them too. So I think the other things I wanted to do is to thank all of our speakers, to Chris Bonnell and to Florence Darlington for their keynotes, and to I think just to think about all of the people that we've had across the stage. I've been doing a tally, because I had nothing else to do. I've been doing a tally over the last couple of days, and we have had 70 people across this stage in the last 2 days. And we had 204 people register. So, we've had a good proportion, somebody else can do the maths, I'm too tired, so a good proportion of people who have been at the conference actually been on the stage. You've heard what they're doing and listened to that, so thank you all very much. I think what I've seen over the last couple of days is a demonstration of the massive value of the school and the collaboration across its members, with public, with practice, and also the work that we're doing in terms of the policy relevance of it. We've had fantastic examples of research inclusion and how we can actually improve and what we're doing to increase research inclusion. Really, really important to make sure that the people involved in research and the people participating in research and contributing to it represent the population at large. We've been answering questions, and you've heard the answers to this, and you've heard projects in Train that are answering questions directly relevant to practice and aligned to the government mission. And you heard the Minister in her address talking about that, and about inequalities. The HDRC is creating that healthier generation, but mostly that prevention and moving into prevention into local communities. And we've heard so much about that over the last 2 days, and all of that is due to all of you and all of that work that you're doing, but not just delivering the work, but also ensuring it gets to the right places and we can create that impact. So I'm going to finish by thanking GJ, Paina May and Rona for co-chairing across the last 2 days. But my final thanks is to all of you. We've had standing ovations for everybody else, and a lot of you've already had at least one, if not two, but you're going to have another one. So I just thank for everybody I've said thank you to, but particularly to all of you for listening, contributing, asking questions, and being part of what's been a fantastic 2 days. Thank you all very much, and safe home, and see you somewhere next year.